Most women have probably wondered just how bad alcohol, tobacco products, and cannabis are in pregnancy. It's fairly common knowledge that those substances aren't healthy in large quantities for you or your developing baby, but we've also all heard stories of women who consumed alcohol or smoked cigarettes during their pregnancies and gave birth to babies that were seemingly fine. Although that may just be anecdotal evidence, this has led some women to conclude that substance use may not be harmful in pregnancy. However, the growing body of research on the topic, including by that of my next guest and her scientific collaborators, suggest otherwise. Substance use during pregnancy can have detrimental effects to both the mother and baby, leading to outcomes ranging from small for gestational age babies to preterm birth, infant death, and short and long term offspring complications. And yet, many questions remain. Which substances are these outcomes most associated with? Does dose, frequency, and timing of exposure in pregnancy matter? What about for male partners? Are their sperm affected? If so, can these adverse effects be reversed or passed down to future generations? We get into all of this today with Dr. Jamie Lowe, an associate professor at Oregon Health and Science University, and Dr. Adam Crosland, an assistant professor also at Oregon Health and Science University. This episode is about substance use during pregnancy. Stay with us. The views expressed on this podcast may not represent those of March of Dimes or its staff. Information presented on this podcast is not medical advice and should not be construed as such. When in doubt, seek competent medical advice. Now, on with the show. Dr. Jamie Lowe, a leading expert on the effects of substance use on mothers and babies in the womb, is a full-time physician scientist, a 2016 K-12 Reproductive Scientist Development Program scholar, and a recipient of the 2020 March of Dimes Basil O'Connor Starter Scholar Research Award, which supports outstanding researchers embarking or continuing their independent research careers. Dr. Lowe specializes in maternal fetal medicine at Oregon Health and Science University, also known as OHSU. She's an assistant professor in the Department of OBGYN and Urology at the university and serves as an associate professor and core scientist at the Oregon National Primate Research Center. She leads a research team to address key gaps in knowledge regarding the effects of cannabis and other environmental exposures on reproductive health and offspring outcomes. Dr. Adam Crosland is a researcher in Dr. Lowe's lab at OHSU, following in her physician scientist footsteps. He is also an OBGYN specializing in maternal fetal medicine and is an assistant professor in the Department of OBGYN at OHSU. Doctors Lowe and Crosland both join me today from Portland, Oregon. Jamie, Adam, welcome to Modcast.
It's great to be here. Thank you so much for inviting us.
Thanks, Alicia. We're excited to be here with you today.
I am happy to have you. So, Jamie, first question for you. Why your focus is substance abuse in pregnancy, the effect on mothers and babies? Why did this become your research focus? Why is this, as a physician scientist, why is this something that really speaks to you?
You know, as a scientist, really a lot of my research is informed by the patients I care for clinically. It helps me really identify, where the gaps in knowledge are and where the need is for additional research. In caring for pregnant individuals, I really realized that we have very limited information to help guide healthcare providers such as myself to counsel patients, especially regarding substance use, particularly cannabis in pregnancy. This really came to light when we saw the prevalence of cannabis use really start rising in the last 2 decades, and particularly during the recent COVID-19 pandemic. People were, using it often to combat stress and mental health, especially in pregnancy. So it's just really important for me to help patients that we care for make informed decisions, not only for themselves, but their offspring. And so it inspired me to kind of focus on this area of prenatal cannabis use.
Adam, what about you?
So not too dissimilar to Jamie's story. As a high-risk OBGYN, we are trained to take care of pregnant individuals with their unique medical needs, either for themselves or their pregnancies. So it was concerning to me as an early career scientist and clinician when I started having patients come into my clinic and endorse substance use, and especially substances that have recently come to market where we don't have good research and good evidence on how to provide clinical guidance. that was a stark realization to me that we really needed to continue investing research and time into this area. And so that was really what pulled me into the area of substance use in pregnancy.
Yeah, and Adam, you use the word endorse. What do you mean by endorse? They were endorsing the substance or they were asking you to endorse it? This seems like a kind of critical part of the conversation and I wanted to clarify what you meant by that.
Absolutely. As we meet patients where they're at, sometimes that can be in their first trimester, it can be in their third trimester, given many different people's circumstances. And so I would say a majority of patients are coming to me saying that they either utilize substances early in the pregnancy and they didn't yet know they were pregnant
Mm.
and want to know what risk that infers for their pregnancy, or they have a history of chronic substance use and are actively seeking help and a plan of care for us to really help them work through this during their time with their pregnancy. So I would say it comes in different parts, but that's how I feel a majority of our patients really present to us.
So most of these women then are coming in with the understanding that it's not great to continue doing this, and can you help me either lessen my intake or completely stop? Is that right?
Yes, I definitely think that that is one of the leading motivations for patients to seek out care.
Yeah. And Jamie, earlier I said that it's widely understood that maternal substance abuse, excuse me, may have an adverse effect on babies in the womb. So it seems maybe like we know everything we need to know. Would you disagree with that? Is more necessary? Is more research necessary? What else is it that we need to uncover?
Definitely. I think that while it's common knowledge that substances such as like cocaine, methamphetamines, or heroin, and even alcohol and smoking cigarettes in pregnancy can be harmful, it's not the same for other substances that are federally illegal, such as like cannabis or psilocybin. And the reason being is these substances have much less safety information. There's very little public messaging regarding the use in pregnancy. And so it's substances like these that we really need to target more of our research on to generate that evidence based information that's needed for patients.
Yeah, absolutely. And the majority of this episode will be about cannabis because that is the majority of your research. And you're right. I mean, we've seen legalization of cannabis. We've seen dispensaries popping up all over, the country. Certainly, states that have legalized it. And I know Adam later will talk about how you're kind of racing against the market, right? Sometimes, which is that this thing becomes legal, yet we still don't know much about it. We don't know about the effects in pregnancy. So I'm really grateful to both of you for doing this important work and very quickly. So Jamie, let's talk more about it then. How common is this in pregnancy? You did say that it was rising in the last 2 decades. It continued to kind of increase. How many women smoke marijuana or vape or edibles or whatever? How common is this?
So as I mentioned, the prevalence of cannabis use in pregnancy has been rising. It can vary anywhere between, 2 to 5% in certain populations to as high as 30 to 35%. And this really just depends on kind of the region of the United States and that we're
Mm.
pulling from. Places that have younger, populations, lower socioeconomics, and more urban populations, those tend to have the highest prevalence of cannabis use.
And what effect does cannabis have on the mother's ability to carry, the mother's ability to carry to term, the baby, whether the baby's
Mhm.
born preterm, after the baby is born? What do we know about? If is it bad? How bad is it?
Yeah. I think while the evidence is growing, there's still some limitations to the studies that are out there. But in general, I'd say the consensus is, prenatal cannabis use is associated with an increased risk for greater odds of preterm birth, small for gestational age infants, perinatal mortality. Even after excluding for prenatal, tobacco co-use, which is pretty common and can also, augment adverse outcomes. Other translational studies, including from our group, have also shown that THC use in pregnancy is associated with impacts to neurodevelopment in offspring, including decreased, brain volume, alterations to white and gray matter. There's also reduced motor development, increased stress and anxiety in infants, changes including to the brain transcriptome and epigenome, including in key genes associated with neurodevelopment as well.
Yeah, and in speaking with you on a background call, you also mentioned autism. There's an increase in risk of that in offspring, right?
There's an increased association of that, both
Hmm.
in large population cohort studies, including a large one done in Canada in the last few years, as well as in the kind of more translational preclinical studies. There's also genes that have been associated with prenatal cannabis use that have been altered with the expression that are related to neural development and autism spectrum disorder and ADHD.
Yeah. Wow. So it's not going to make your baby more relaxed, or easier. Because people think marijuana is, and oftentimes people experience marijuana as something that calms you down, something that releases stress. But in fact, it can have really really serious effects on your baby.
I think that it can have, kind of short and long term effects that are not always obvious during the pregnancy itself. And some of these have been described as like increased cry, harder to, more sleep disturbances in neonates and infants. And then later in, kind of early childhood, harder time for kids to pay attention in school, more hyperactivity,
Hmm.
increased, cognitive issues. And so definitely, we're uncovering kind of more effects, across the lifespan of individuals that were exposed to prenatal cannabis use.
Yeah, and how much are we talking? How much marijuana does or cannabis does a woman have to use in order for her risk to be quite significant for these adverse effects?
That's a great question. We're still trying to uncover that. Right now, I would say it's most consistent with individuals that chronically use cannabis, so regular, almost near daily use. But it really depends on, the mode of delivery. Like, are they smoking? Are they vaping? Are they using edibles? And then also how frequent, the potency. So there's many things that factor into, that link. And unfortunately, in a lot of human cohort studies, self-report of cannabis use is unreliable. It's unclear how much people are actually using. So it's hard to say, what amount is really linked to some of these associations that we're seeing.
Yeah, and I bet for some of these women that are coming into clinic seeing you or Adam, and they're saying, I smoked in early pregnancy before I knew I was pregnant. I stopped, and they continue not to smoke during their pregnancy, or even for women who smoked before their pregnancies and then don't smoke at all during their pregnancy. Maybe they look forward to giving birth so they can finally, smoke again. But then of course there's the period of breastfeeding if a woman chooses to breastfeed right after birth, and so or for an extended period of time after birth. What do we know about breastfeeding and cannabis? Because I certainly know I've had girlfriends that say, I abstained during pregnancy, but once my baby was born, I continued again because my baby was born already, right?
Mhm.
It's no longer inside me. But breast milk, as you've shown, is THC is transferred through breast milk, isn't it?
Definitely. And I think, while a lot, we've already shown, a lot of individuals that use prior to pregnancy, more than half continue to use during pregnancy. Similarly, those who use during pregnancy will continue during the lactation period,
Hmm.
postpartum, especially within the first 2 months of childbirth. And what we do know is it doesn't seem to really affect maternal milk supply,
Hmm.
but we have been, it's been shown that THC can be passed through breast milk to offspring. And because of this, currently, like the CDC, the American College of Obstetrics and Gynecologists, and the American Academy of Pediatrics have recommended against cannabis use while lactating because there's just very limited safety data. We don't know how much individuals can use while breastfeeding that's safe. We do know that, when people smoke cannabis, THC levels peak about 1 hour after inhalation in breast milk. It's detectable for up to 6 days after. Prior studies have also shown that infants are ingesting on average about 2 to 3% of THC that mom is using. There's also kind of some studies that have supported that infants that were exposed to THC through breastfeeding have decreased motor development, increased lethargy, issues with feeding, growth delays, and so because of this right now, kind of the recommendation is try to abstain when you're breastfeeding if you can.
Yeah. And I really like that, if you can, because, and I know, because obviously we did some preparation for this interview. I spoke with you, Jamie, I spoke with Adam. We were all in an email thread together, and you guys both had this kind of non-judgmental attitude about this, and you need to be that way, don't you? Because otherwise you turn these women away, and they feel judged, and maybe they will smoke more, or use another substance more. So I just really like that it's not a hard and fast don't do this. It's not good for you, you shouldn't do it. But if you can't stop completely, please try to decrease your consumption, or whatever. And so I just want to say that I really appreciate that you both kind of take that perspective and that approach to your patients. And I think that there's always a gray area. And so I'm glad that you're kind of leaning into it. Adam, Jamie mentioned earlier, it's really tough to know, how much a woman is actually consuming, what
Mhm.
percentage it is of THC, all that stuff. And so I just wanted to talk to you a bit more about the difference between smoking, vaping, and edibles, because vaping has really risen. I think in the last 10 years, a lot of people are vaping, and they think it's better for them than smoking maybe a joint or something like this, or from a pipe. Edibles, I think, had their heyday maybe 20 years ago. I'm sure that people still eat edibles, but what do we know about the differences? Which one is better, worse for you? Do we know anything about that? And during pregnancy too.
Yeah, you're right, Alicia. It's a hard question to answer because I think there's several variables that really play into this exposure model. Because it's, I think, one of the biggest challenges that researchers in this area face is trying to objectively quantify exposure. So you brought up just one factor there, that is like the actual modality of delivery. How are people getting THC and cannabis? Is it smoking, vaping, or is it an edible? Just the delivery mechanism in and of itself can impact how much somebody is exposed to cannabis or THC. And some of the other things that we also think about in terms of exposure is the actual content of what they're taking in. So, strain and potency
Hmm.
can all play into this formula and this picture here of exposure. And surprisingly, maybe for some and not for others, there was a publication in the Journal of American Medical Association that only about 17% of labeled cannabis products actually contained what they said was contained on their ingredient and packaging labeling. So it's really hard now for people who even appropriately report what they are taking. Do they even know what they're actually taking in and how much of it? So there's so many of these different things that I think make it hard for both patients and for researchers to really get a handle on the exposure question here.
Yeah, absolutely. And out of curiosity, that 17% that we actually know the label was correct, the rest of the 83%, was it higher potency of was the content stronger? Like, was the cannabis stronger or weaker? Are women actually taking in more than they're being told they're taking in, or are they taking in less? Or do we know?
Good question. I think that the original study was actually just reporting a difference. So they did capture if it was under or over, but I think their main outcome was whether it was primarily different.
Yeah, okay. So, all right. Well, let's move on to, we've been talking about women, right? As we know, when it comes to all issues of reproduction, there is also usually a man. Some of the effect also comes from the male partner sometimes. So let's on to cannabis's impact on male fertility. Jamie, I learned this when I was researching you. It's on your website. Your research on the effect of cannabis on male reproductive health in monkeys was featured on Jimmy Kimmel Live in 2022. He actually used your research to, I guess his researchers, his editing team found that your research fascinating, and they included it in his maybe opening monologue. And so let's talk about the research quickly, and then we'll move on to what Jimmy said about it, which is I think also very important. So your research showed that bilateral testicular volume decreased by 58%. That's a lot after 7 months of chronic cannabis use in these monkeys, and that their male reproductive hormones, including testosterone, also decreased. Tell me more about what that means. Does that mean that they made less sperm? Their sperm was less effective? It was morphed, like it was a mutated sperm? What did that mean?
Definitely. I was, as a researcher, making it onto late night TV is definitely on the bucket list, but didn't think I would be able to achieve that so early. The study itself that you alluded to, basically the findings suggest that chronic THC use, even at a moderate dose, has an adverse impact on male reproductive health and fertility. It is linked to, decreased testosterone, testicular atrophy. It can alter the sperm DNA, including genes involved in nervous system development and function, and including autism spectrum disorder. And these epigenetic changes may be passed along to future offspring. And a lot of folks that are using cannabis will likely not be impacted by their ability to conceive, but in those that have subfertility or infertility, it could be a contributing factor, and they should be counseled to stop, or at least, use less or less frequently.
Yeah, and another paper of yours also showed that, like you just said, they should be counseled to use less or to stop. And actually, using less and stopping, especially, works, doesn't it? Your paper showed that it had a restorative effect on, male reproductive health. Tell me about that.
Mhm. It was inspired by the fact that we realized, in our patients, the next question after we had our initial findings would be, well, then can I stop and reverse these findings? And
Right.
so we extended our studies to look at, whether cessation of THC was beneficial. And what we found was that even abstinence for 4 months, which is about, 4 spermatogenic cycles, it was associated with partial reversal of some of the changes that we observed, including testicular volume, testosterone, estradiol levels, sperm DNA fragmentation, and changes to the sperm epigenome and seminal fluid proteome. And so, it says to us that at least with 4 months, there's at least partial recovery is possible, and potentially even longer, there might be, kind of reversal back to baseline per se. We have extended our studies to know that at least by 2 years, everybody has reversed back to baseline. Whether between the 4 months of the 2 year mark, we haven't investigated that time frame, but definitely those who can abstain, this will definitely be beneficial to those that are trying to conceive.
Okay, very cool. Now back to Kimmel. So he mentioned some celebrities who are known cannabis smokers. I think like Willie Nelson and Snoop Dogg. And he concluded, and he mentioned them. Hey, what about these guys? They have a lot of kids. And he concluded that the average weed smoker who also wants to be a father should be okay. You mentioned earlier that the average man who smokes won't probably be affected in his ability to have children, but somebody with subfertility or other issues could be now put further at risk. And but what Kimmel said, this anecdotal evidence of these celebrities that have a lot of children, meaning this won't impact you, it can be really persuasive and can detract from the message of the scientific findings. And like you said, it's not going to affect everybody, but it will affect people that might already be struggling a little bit. But I imagine that you might have, that what Jimmy Kimmel said might also be indicative of the problem that you guys run into a lot of the time, right? Which is that it's so culturally, ubiquitous. It's like, smoke a joint, no problem. One here, one there, and you must be running up, against this all the time. When actually and it's a relaxing thing. It's a medicinal plant. When the research shows it's quite damaging. Adam, do you have a take on that?
Yeah, I think you bring up a very big point that I think both society and researchers contend with, and there's so many different factors that go into influencing the narrative around substance use and reproductive health. And one of those big factors, as you correctly identify, are anecdotal stories. So I will never discount anyone's pregnancy journey or their experience, but how we capture people's experience and process that information into meaningful data is important. And everybody's experience, their pregnancy experience is valuable and important, but rarely does it ever give the complete picture. And so, as researchers, we have systematic ways to collect people's stories, so to speak, and objectively translate that into bigger pictures and larger data so that we are actually able to inform the public and not just base it off of one singular story where individual circumstances are oftentimes not held constant from person to person. So we really want to make sure that we're staying away from just using one person's story to base the entire population's safety and pregnancy counseling around. So I think that's one of the big things that we want to make sure don't happen. And as you previously mentioned earlier, we often do find ourselves racing against the market because when substances become widely available, it's not so far fetched for people to think, well, if it's safe and I can go out in public and buy this, then it's somebody's probably vetted it. It's probably safe. But oftentimes, how something comes to market isn't through it being researched in every different type of population. And as many people know, the pregnant population or people of reproductive capacity, that is a huge community that is largely under researched and oftentimes one of the last ones that are included at the research table. And so we are kind of stuck in this time period where people have access to something and it can occasionally be mistaken for safe, but it's actually just available. And so now scientists and researchers have to kind of fill that gap as quickly as possible to make sure that people are getting safe and accurate information.
Yeah.
And I
Well, go ahead, Jamie.
I was going to say, I think it's also important to remember that just because someone's able to conceive or they didn't lose a pregnancy doesn't mean effects have not happened, including some of the things that I described, which are short and longer term offspring outcomes in regards to behavior or neurodevelopment or cognitive function. These are things that won't come to light until much later, and the association to be directly tied back to cannabis use preconception or during the prenatal period is difficult. And so I think that's just where we need to also to remind individuals to think about harm reduction and options for other substances to take the edge off, or for relaxation that may not have associated side effects the way cannabis does.
Yeah, absolutely. Fantastic point, Jamie. I'm really glad you brought it up. Just being able to give birth is not the end of the story, right? You want a healthy
Mhm.
child. Um, and Adam, I want to mention, and Jamie, I want to talk about some of the alternatives, not alternative, because that also sounds like a drug now when you say alternative substance, but literally an alternate what are you guys, so let me ask you now, Jamie, what are you guys, and Adam, what are you guys counseling your patients to do? They say, because we hear that marijuana is not technically addictive, right? The way that opioids are, maybe, but we also know that behaviorally it's pretty addictive. So, what are you counseling your pregnant moms or pregnant individuals to do that say, I'm really stressed. I need to do this. I know it's really bad for my baby. I want to stop. What else can I do? What else can I
Yeah.
take? What else can I drink? What else can I do? What are you counseling them to
Well, I
do?
just wanted to quickly comment on the point about it's not addictive. It actually is.
Really?
15 to 20% of individuals that use cannabis regularly in pregnancy have cannabis use disorder, which is listed in the DSM as an addiction. And that in
Okay.
itself, separately from just cannabis use in pregnancy, if you have cannabis use disorder, that is also associated with increased adverse outcomes in pregnancy as well. So I think that's also something important, for the public to understand,
Yeah.
that it can be addictive for some, not all. And I think it depends on, what you highlighted. The conversation will be tailored to why they're using cannabis. So it's really asking the why. And, for example, most commonly we see it for kind of nausea and vomiting, especially in the first trimester. And that's when, I would recommend using other alternatives such as B vitamins, which is what the American College of Obstetricians and Gynecologists recommends as first line, therapy for individuals experiencing nausea and vomiting of pregnancy.
Yeah,
And to kind of
absolutely.
dovetail what Jamie was saying, I personally, if people are using it for coping mechanisms, we try and figure out what are they trying to cope for and what are their other coping abilities? So how are they handling? Because many people do, like you described, Alessia, use it to take the edge off. And that's not dissimilar in pregnancy. Pregnancy can be a very stressful time for people.
Yes.
And so when we're trying to understand what those stressors are, can those stressors themselves be mitigated or taken away? And if not, how do we provide positive coping behavior mechanisms for people to learn and develop so they're not solely relying on cannabis, for example, if that's the reason that they're using it.
Yeah, and at your hospital or in the OBGYN department in maternal fetal medicine, you guys provide a holistic kind of answer, right? Solution. You have counselors, you have social workers, I'm sure you have nutritionists, all sorts of stuff that you say, listen, we're here to help you.
Mhm.
And
Exactly.
Absolutely.
Adam, you mentioned earlier something interesting, and I don't want to take you know, the conversation in a political, regulatory direction, but I do wonder, is there precedent for something that has been approved by the FDA for widespread use, then being either pulled off the shelves or having a label put onto it saying recent research has shown that this is not safe for a pregnancy? Like, is that kind of the goal here? I mean, I know obviously the goal is to counsel every patient and help every woman or man or trans person that comes into, or non-binary person that comes into the clinic. But the secondary goal is there an attempt here to say, listen, guys, we move too fast. This is not safe in pregnancy, and maybe there can be a warning label on, on the door of a dispensary or something like this. Is there do you think that, and I'm not asking whether your research is going in that direction, but is that maybe somewhere where we could end up in the next 5 to 10 years as you and your colleagues do more research that illuminates the truth behind cannabis in pregnancy?
I think the mechanism of substances getting to the market is a beast in and of itself, and that has its own process. I think one of the big ways that the healthcare community can really help protect people is by making sure that those types of public health minded messages are in the forefront of marketing and advertising. So it is making sure, because there are many, for example, with cannabis, alcohol, you'll see those labels anytime that you purchase those things, but oftentimes that is marketed in a secondary fashion compared to people just trying to sell it via advertising. So I think
Yeah,
while we might not be able to today turn the tide and make everything researched thoroughly before it gets to market, I think that right now what we do have the capacity to actually do is we have to have stronger public health messaging about what we know and about what we don't know. And
yeah,
that's not revelatory. We have this with many different types of medications in pregnancy where we say this just hasn't been that well researched, or there has been some research on this, but it's only been in animal models, for example. So it hasn't been actually researched in humans who are pregnant. So it's a process that we already do, but we could do it better.
yeah. And we know when we talk about labels, there are labels already on alcohol, and labels on cigarettes, and people are still smoking and drinking, right? So I think that actually what you guys are doing on a person to person basis and in your labs, is probably the most powerful and effective way to kind of tackle this. So again, I thank you for that. Let's turn now to alcohol. This was surprising to me, but half of women drink in pregnancy. I guess. Jamie, how harmful is alcohol consumption in pregnancy? Moderate alcohol, a glass a day, is that okay? What about heavy consumption? Does the type of alcohol matter? Is wine all right? Is beer okay? Is whiskey bad? What do we know?
What we do know is we don't have any safe amount of alcohol to recommend to consume in pregnancy. We There's some data that shows moderate alcohol consumption has been linked to harm. Most of the data, though, consistently supports binge drinking or heavy drinking during pregnancy, having adverse outcomes on the developing baby. Binge drinking is described as, kind of 4 or more drinks in a short period of time, and heavy drinking is 8 or more drinks in a week. We don't think that the type of alcohol really seems to matter, but because most often when people are using alcohol in pregnancy, they're also using other substances, particularly cannabis or tobacco. And we know that using multiple substances, definitely you can augment your adverse outcomes. And so recommendations should be focused on, if you're using multiple substances, try to cut down to, one, less is better, and that's kind of the focus for harm reduction in this population.
Yeah. Let's talk about opioids. These are, heavy drugs that produce feelings, basically painkillers that produce feelings of euphoria in users. We've heard a lot about, obviously, heroin a long time ago, still a very hard street drug, but more recently, oxycodone, hydrocodone, fentanyl has been absolutely massive in the news in terms of overdoses, especially among young people and probably also the pregnant population. And so obviously there's an opioid epidemic in this country. I'm guessing it does not discriminate against pregnant women, that pregnant women are actually using this substance. Adam, what are you seeing at OHSU?
You're correct, Alessia. Opioid use does not discriminate and does impact the pregnant population. As we've seen opioid use increase in the country, I think one of the positive things to highlight is that our hospital, like others, are increasing um, the substance use programming and specialty teams that are really multidisciplinary at their basis. So they will include addiction medicine specialists, maternal fetal medicine specialists, other prenatal care providers, mental health counselors, really everybody who is involved in making a safe and good plan of care for these patients. And we're meeting these patients both in the inpatient and outpatient setting where they are. Is if they are coming and seeking care, that means that there's a conversation to be had, and that's where we need to start. And I think that is something that we are seeing better success in, is that when we approach patients where they're at in a non-stigmatizing way, these multidisciplinary teams really have the best chance for improving outcomes for pregnant individuals if we really foster this environment around non-judgment.
Yeah. And what do we know, Jamie, about the risk of offspring whose mothers were opioid users in pregnancy, also kind of being drug users in the future and having a dependency later in life on opioid use or other drugs?
The data really supports that offspring exposed to maternal substance use during pregnancy have a higher likelihood of addiction vulnerability and substance use later in life, and also psychiatric disorders as well. Part of this is because when offspring are exposed to substance use in pregnancy, it can change different parts of their brain that play key roles in reward processing and making them more susceptible to, developing addictive behaviors later in life.
Yeah. We've talked a little bit about COVID throughout the interview, but I wanna and I've heard both of you say that substance use increased during COVID. Has it leveled back to where it was before COVID now, or are we now kind of at a new high with the pregnant population? It's a question for either of you, maybe
I
Jamie or
think
Adam, whoever wants to tackle that.
with the COVID pandemic, I think we are still in, or I think from a societal standpoint, we're in kind of the post-pandemic stress.
Hmm.
So I think during COVID, society has adapted in many different ways in how we deliver healthcare, the education system, people's jobs, their day-to-day, how they go to work, if they go to work. People are now sometimes completely remote. And some of these really big shifts in what were previous societal norms have invoked a lot of stress. And for some people, that has prompted good change and as can be and it's easy to see that it can also play a negative role for some people. And so I think as the immediate COVID related stressors have subsided, this new post pandemic era and adaptation that we've had to go through kind of brings these new sets of stressors to the table and different anxieties for people. And so people are still continuing to cope with substance use during this time as well.
Agree.
Yeah.
And, as you mentioned, during the actual pandemic itself, prenatal cannabis use increased up to, 25, 30% in certain regions of the United States because pregnant individuals were, looking for options and ways to mitigate the stress that they had from the pandemic, to treat mental health, because a lot of mental health services were, pretty limited across the country during that time. And so I think it really just highlights, the important, need for messaging, what we don't know about cannabis use in pregnancy and what we do know about the safety, and also increasing mental health services for pregnant individuals as well.
Yeah, absolutely. Earlier, Jamie talked about how, yes, children of mothers who use opioids or other substances do have a predisposition to become users themselves later in life. I'm guessing that was a genetic link, Jamie. But Adam, we also know that there are epigenetic associations here that women can, without actually altering the gene sequence, there can be a turning on or off of genes epigenetically based on the mother's behaviors during pregnancy that can affect the baby after it is born. How can we reverse this epigenetic cycle? And I ask because one of our Basil O'Connor, Jamie, this will interest you, one of our Basil O'Connor winners, no, I'm sorry, one of our Discovery Award winners from last year, I believe, a man named Dr. James Collins, he did really interesting research on essentially that it takes 3 cycles. So the grandchild of the grandmother that was born into poverty, and we're talking about Black women here, will not experience preterm birth with her own baby if there are, like I said, 3 cycles of economic upward mobility. And I might have gotten the details a little bit wrong there, but essentially, extraordinary news about how to break this epigenetic cycle. What do we know about how to break epigenetic cycles in terms of drug use for pregnant women? Is there anything, and what are you doing, or have you seen done to kind of disrupt these long-term intergenerational effects?
Yeah, I think you started to actually hit on one of the points there, Alessia. I think when we consider disrupting this epigenetic cycle, we are really needing to look at this through a public health lens and target risk factors that contribute to epigenetic change. So, one big category that comes to mind are social determinants of health, like you brought up. So, these are present from the very beginning of pregnancy. So, we need to address risk factors for substance use and ensure that pregnant patients have comprehensive prenatal care and support. So, one of the early activities that can be done is early and effective intervention for substance use disorders. So, actually interrupting the use if possible or mitigating that exposure can really play a critical role early on in the cycle. Like I said, comprehensive prenatal care, nutrition, mental health support, social services, these are all things that can help target factors that we know contribute to epigenetic changes in the offspring. And this doesn't just stop, like you mentioned, the cycle, it continues through pregnancy and after pregnancy. So we have to consider the postpartum period as well, offering a supportive postnatal environment. Again, nutrition, stable housing, positive caregiving. These are all tenements to social determinants of health that can help remodel or mitigate these epigenetic changes. And we still need to, again, endorse and lift up the research that is being done in this area, because we still have to better understand. We're just seeing the tip of the iceberg in terms of how long certain epigenetic impacts last for, and to what degree can we change the tide for some of these. And that is all going to be dependent on the different factors that influence them. So we have to keep looking at this. We have to keep supporting the research in this area so that we can really both address the biological and social factors, to have a real impact in this area.
Yeah. And I forget the other portion of cannabis. What is the other portion of cannabis? There's THC, and then there's the other thing. And that has been really sold a lot more now in the market. What am I talking about here, guys? What's the name? I'm
Cannabidiol, CBD.
CBD, right. So, Jamie, let's talk. I know this wasn't something that we talked about earlier, but I want to talk about CBD because companies started selling CBD and saying there's no
Mhm.
THC here, but this is really going to relax you, almost like an alternative to the drug. Do we have any research on the effect of CBD in pregnancy? And is it? I guess my main question is, does it actually calm you down without providing the negative effects of THC? Could this be an alternative that you even suggest to patients?
I think there's a lot of potential for CBD to be having associated with a lot of beneficial effects. The problem is the research has been really tricky to conduct because CBD is not FDA regulated, meaning a lot of CBD products don't just contain CBD. In fact, a
Mm.
prior study found out that 20% of CBD products actually had THC in them,
Oh my
and
gosh.
can also have other things like fungus or bacteria and lead or other
Mm,
contents. And so
mm.
it's really hard to say, if somebody's taking CBD and we see certain effects, is it really the CBD or is it some of this other contaminants that are in CBD products? So I think that's another area that's really important for research to focus on, especially combined THC CBD products. I think the ratio that's been most used for medicinal purposes is a 1-to-1 ratio, and that would be important to study in pregnancy in the future.
Yeah. Thank you very much for mentioning that. Because that would be, we would be amiss if we
Mhm.
remiss if we didn't mention that. That's a big part of it, I think. Now, Jamie, obviously we've been talking a lot about cannabis here. Your focus is cannabis in pregnancy. Your research and the research of others has shown that it should be, if not completely avoided during pregnancy, limited. Yet, as we also discussed on the podcast, the number of women smoking, vaping,
Mhm.
or eating is rising. Are you hopeful for this population and future generations? And why or why not?
I think that rising cannabis prevalence that you alluded to is, largely because of two reasons. One, limited evidence-based safety data that leads to, individuals having, perceptions that cannabis is not harmful. And two, there's really been limited and inadequate patient counseling by healthcare providers, giving, resulting in lack of patient awareness regarding the risks associated with cannabis use. So because of those two things, I'm really hopeful for change because I think that there's, better data coming out, including from our group, targeting, the paucity of evidence-based data that's out there. And then there's also been increasing resources to help disseminate this information as well to other researchers, healthcare providers. You know, our group alone, collaboratively, we've developed a couple different tools, including one of them is an online cannabis resource with the help of the U.S. Department of Veterans Affairs and the Office of Rural Health to provide, clinician briefs for medical providers that are taking care of patients with cannabis use and how to have those conversations with them. And then there's
Fantastic.
also a program called Extension for Community Healthcare Outcomes, or ECHO. This is a platform that exists in different parts of this, US and including across the nation. That's a telemonitoring model that helps healthcare providers, especially in underserved areas, become experts in caring for the patients that live around them. And we've developed an cannabis echo that was launched in Oregon, as well as also the nationwide, Veterans Affairs hospital system program. And this is attended by, somewhere up to, 500 providers per session. So hopefully through these kind of, platforms and opportunities, we can help, start educating other healthcare providers and patients and the public.
Yeah, absolutely. And like I said earlier, I think the most powerful tool is you, Jamie, and you, Adam, and just that in that white room with that patient, just eye to eye, saying, "I care about you," and I'm going to help you, not you have to quit. I have to help. I can help you. I'm going to help you, because I think that human attachment is the thing that drives all of us. And if we have somebody in our
Mhm.
corner, we're willing to do whatever it takes, especially for the baby in our belly. So I thank you so much both for your work, your empathetic and compassionate approach, your wisdom and understanding that this is something that is completely unstudied or understudied, and going down this path. It seems like there's a lot more fantastic research to be done, and for coming on the show. Thank you so much. It's been a pleasure having you on.
Thank you for having us.
Thanks. It's been great, Alessia.